We're doing a sound check. Right. Can we have some feedback whether we've got sound, please?
Hello.
Shamrus, can you hear us?
Yes,
All right.
very
Yeah,
clear. Yeah.
all right. Okay, thank you very much, because I had a warning notice just now the browser lost connection with the sound. Okay, anyway, we'll wait for more people to come online. So we'll just run our usual SJMC introduction to our Grand Rounds video. Then I'll take you through some housekeeping slides, okay? Okay, and a little reminder about our CME.
Welcome to another CME session from SJMC. We hope you enjoy the content.
All right, thank you. I'm here. I'm Alan Tay, also known as Couture Dobbs, and I'm here just to introduce the session before I pass on to the moderator, who is Dr. Kanan. I'll just take you through some housekeeping slides, yeah? So today's topic is SJMC Cardiology Grand Round number 27 on dyspnea, common symptoms, and different pathologies. There will be a CME awarded for attending and viewing this session. There will be a QR code presented at the end, and also we are going to take comments, questions through Slido. This QR code is not for CPD points, it's to join the Slido. You can join slido.com and number 558383819, or you have the Slido app, just put that number in, or if you just scan it with your phone camera, it'll take you to Slido and straight away to our Q&A session. You can also use, if you're watching on YouTube, you can comment on our YouTube chats, and we'll add your questions or comment as well. Okay, but we prefer you to use Slido, please. This is about the CPD point. This session is eligible for 1 CPD point, and the way you should claim it is there will be a MMA QR code displayed at the end of the talk, and you can scan the code with your MMA app and claim the point the usual way. For those of you who are not aware, if you are, the previous complaint was you are watching from a mobile phone and you can't scan what you're already watching, you can take a screenshot and save it to your photo album. And now, if you look at on the right-hand side, there is a album. The MMA app has an option to scan the QR code from a saved image. So you just click on album, select the QR code screenshot you've done, and you will be able to claim the point that way. So you now can watch the device and also scan and claim the point. And I'll be displaying the QR code towards the end after the Q&A. All right, so that's housekeeping, and I'll pass over to Dr. Kanan, who is the moderator for today, and he'll introduce the rest of the speakers. Over to you, Kanan.
Thank you, Alan. Thank you for the invitation. Ladies and gentlemen, thank you for joining us for yet another Saturday session. This is our 27th in the series, and we are discussing dyspnea. Today, we are very privileged to have in our panel Dr. Balachandran, Senior Consultant Cardiologist. This is going to be his debut webinar in SJMC, and I hope that you'll join us for many more sessions to come. I'm also informed that this is Dr. Nazrul's debut session, and then you have the rest of us, Dr. Naveen, Dr. Shamrus, and of course me. And on to you, Nazrul. We have got interesting cases. We want to get going.
Okay. Can you open? Okay.
Thank you, Dr. Kannan, for the kind introduction. So I'll start off with my first case. So I had a 71-year-old female who came to my clinic earlier this year. She had a background history of hypertension and dyslipidemia, for which she's taking amlodipine 10 mg once a day and simvastatin 20 mg online. Besides that, she also had a history of COVID infection early in 2022. She was not warded or admitted at the time, and she was very stable. Now, she's been under follow-up with Klinik Kesihatan Sungai Buloh for her comorbidities. She's also a non-smoker. She doesn't have any family history of RHD, and she's a non-diabetic as well. So, on further history, she's been having exertional breathlessness for the past 1 year. She doesn't have any history of chest pain. She doesn't have any asthmatic symptoms, and she doesn't have any obstructive sleep apnea symptoms as well. 2 months into her symptom onset, she was actually referred to a tertiary hospital. She had an echocardiogram and an ECG done there, and she was told that everything was normal. However, during the course of the year, her symptoms had progressively worsened. So when she came to the clinic on physical examination, she was speaking in sentence, but at the end of every sentence, she was very breathless and she had to pause for a minute before continuing to speak. She was obese. Her BMI was 29. She was pink. Her JVP was not elevated at the time. As you can see, her blood pressure was extremely high at that time. It was 196/80, and her pulse rate was 90. On auscultation of the chest, her lungs were clear. There was first and second heart sounds were heard. There was no murmur, and clinically, her heart was not dilated. She also had no pedal edema. So, based on all this information that we have, I would just like to pose a question to Dr. Kannan. What do you think would be the differential or the working diagnosis at this point in time?
Thanks, Nazro. Okay, what's very obvious is that her blood pressure is very high on presentation. So one of the first things I would want to think about is hypertensive heart disease causing her symptoms. Now, her BMI is pretty high, it's 29. So obesity and possibly Pickwickian syndrome can also contribute to her symptoms. Now, given her comorbidities, ischemic heart disease is an obvious thing for us to consider. The other thing is we haven't got any results yet, but because she is hypertensive with a high blood pressure, she may have renal disease. Maybe this will have caused anemia. And in the course of investigations, we have looked for anemia, whether as a cause of breathlessness. These are some of the things I will consider.
Thank you, Dr. Kannan. So we did some blood tests and imaging tests for her. So I'd just like to go through her blood test first, and maybe Dr. Wala will have a few words regarding her blood test.
Hi, good afternoon to everybody. This is a very interesting case presented by Dr. Nazrul, a 71-year-old lady who comes with exertional dyspnea. What's striking here is that her hypertension, which is very poorly controlled. Well, these are the initial blood tests done by Nazrul. What we can see is that the usual normal ones are the hemoglobin 13, creatinine 50, the thyroid function is normal, HbA1c is 5.5, LDL is 1.9. What is striking here is NT-proBNP, which is 1,500 picogram per ml. As we all know, the norm, this is investigation done in patients with shortness of breath or exertional dyspnea. I just would like to go through some aspects of this B-type natriuretic peptide and NT-proBNP. This very interesting factors which we investigate nowadays for patients with heart failure. In recent years, biomarkers have emerged as important tools for diagnosis, risk stratification, and therapeutic decision making in cardiovascular disease. Usually, as before, we use troponin T in particular, which has become the cornerstone for diagnostics and workup for patients of ACS. Now, other new markers include B-type natriuretic peptide, which is BNP, and its N-terminal fragment, which is proBNP. These are diagnostic usefulness and is progressed from benchmark to clinical applications. This BNP belongs to the natriuretic peptide, family together with other structurally similar peptides, namely atrial natriuretic peptide, C-type natriuretic peptide, and the urodilatin. BNP is synthesized as a pre-hormone. It comprises 108 amino acids cleaved in equal proportions into the biological 32 amino acid and the biological inactive 76 amino acid, which is a anti-fragment pro-BNP. So the main stimulus for increased BNP and anti-pro-BNP synthesis and secretion is myocardial wall stress. So in patients who have any symptoms suggestive of heart failure, the pro-BNP value goes up. The physiological effects of BNP is natriuresis, diuresis, peripheral vasodilatation, inhibition of the RAS system, and the sympathetic nervous system. Its clinical application is very useful. It's used for patients with elevated values with heart failure. Nazrul will show me the values which are diagnostic for heart failure. The cutoff points for heart failure diagnosis is shown in the slide. Patients with NT-proBNP, heart failure is possible with 300 to 450, but if it is more than 450, it is most likely to be heart failure. As in our patient, the value was 1,500. ProBNP also has been shown to help in our management of heart failure. It has been reported that BNP and NT-proBNP can be attenuated by treatment with drugs such as ARB and beta blocker. So it guides us in our management of heart failure cases. This is the most important facts of BNP and pro-BNP in heart failure. Nazrul?
Can I ask one question, Dato' Bala? Anti-proBNP levels also vary with age.
With age, yes.
Yes. So if you're older, you might have a higher level, but that might not indicate that you got heart failure.
Yeah, it is shown in this slide also. Okay. Anything between 50 to 75 years old, heart failure is most probably possible if it's more than 900. And if it's more than 75 years old, it's more than 1,800 picogram per ml.
Thank you, Dr. Bala, for the very comprehensive explanation on BNP. So just to recap, our patient actually is 71 years old and she has a BNP of 1,500. So based on this value, she likely has got heart failure. So we also run a few other tests for her, and this is a chest X-ray that was done. Maybe Dr. Shamus can give a few words on what he sees.
Hi everyone, thanks for joining us again. Yeah, on the X-ray, looking at the slides, the heart, the most obvious features I can comment, the heart size looks enlarged. I'm not sure whether this was an AP film or proper PA film. And maybe some, if you can convince yourself, some upper lobe diversion there in the hilar region.
Okay, all right, so this is a ECG, Shamros. Anything like
ECG, I mean, given the background of hypertension, I want to see the most obvious features, whether there are any signs suggestive of left ventricular hypertrophy, voltage criteria. But on this ECG, I don't see anything obvious to suggest LVH voltage criteria, and there's no obvious ischemic signs or any prior infarcts on this current ECG. Yeah.
We also did an echocardiogram for her, and these are the results. Dr. Shamus, maybe you'd like to describe them?
Okay, I mean, maybe you want to point to the GPs out there.
Yeah.
See the pointer. I mean, leftmost pictures, that's a short axis view. You can see the left ventricle contracting very well. I think the ejection fraction is normal, but something that is obvious in this patient is the left ventricular wall thickness. It looks thicker than normal. I think this patient has left ventricular hypertrophy based on this echo.
Yeah, the other thing that I would like to add on, if you look at the image on the right hand side, this is the apical four chamber view. So what
LA was method
Yeah,
also.
we're looking at the LV, RV, LA, and the RA. As you can see, her left atrium is dilated. So this is a very common finding in patients with a very high elevated left ventricular end diastolic pressure, which we commonly seen in hypertensive heart disease. Yeah. So, Dr. Chambers, would you like to comment on her Doppler findings?
Yeah, I mean, the most obvious thing, I don't know whether
Sorry.
you can see this value here, E over E prime. Usually if it's elevated more than 10 or 12, usually it's indicative that this patient has some sort of diastolic dysfunction.
Okay, thank you. So based on her echo findings, her blood tests, and her physical findings, we could agree that she most likely has got heart failure, possibly with preserved ejection fraction. Yeah.
Can I make one comment?
Yeah.
This is a good time to point out that the sensitivity of the echocardiogram to pick up the presence of left ventricular hypertrophy is much higher than the electrocardiogram, as clearly demonstrated in this case. Now, in this case, we found that the ECG did not show any evidence of left ventricular hypertrophy, which was very evident on the echocardiogram. Now, sometimes in clinical management, we find it difficult to establish whether a patient really has got high blood pressure because the readings can be variable in the clinic. And sometimes we perform an echocardiogram, and if the echocardiogram shows left ventricular hypertrophy, then it helps us with the diagnosis of hypertension in that particular patient. So echocardiogram is more sensitive than the ECG for diagnosis of left ventricular hypertrophy.
Thank you, Dr. Penny. So now the other test that was done was we did a CT cardiac for her. Now the reason for this is looking at her comorbidities, being a hypertensive, her advanced age. We would like to rule out coronary artery disease as a cause of heart failure. So as you can see here, that she had surprisingly very clean coronary arteries. We don't see any plaque formations, or we don't see any calcifications on all three arteries. So what we did for her initially, so our diagnosis, we think, is that she most likely has got uncontrolled hypertension, which has led to her developing heart failure with a preserved ejection fraction. So we admitted her to the ward. We gave her a very low dose of Lasix, and we actually started on Entresto 50 milligrams BD as well as empagliflozin 10 milligrams once a day. She tolerated the medications well. On the second day of admission, her blood pressure had come down slightly to 140/80, and her pulse rate was 90 beats per minute. She reported that she was feeling much better, so we added a low dose of bisoprolol for her at that time, and we continued her on low dose diuretics. On day 3 of admission, her blood pressure control was much better. It had come down to 130/80, and her pulse rate had also dropped to 80 beats per minute. She was feeling less breathless. She was able to ambulate to the toilet without much difficulties, and at that point, we switched her to oral Lasix. We also decided to start her on spironolactone at that time to actually help her with the heart failure. She was subsequently discharged the next day, and we saw her in the clinic 1 week after discharge. She was feeling much better. She was able to complete her sentences without much dyspnea. However, her blood pressure at home wasn't very well controlled. The BP ranged from 140 to 150, 80/90. So we increased the Entresto to 100 milligrams twice a day, and increased the bisoprolol dose as well to 2.5 once a day. Her anti-proBNP levels had come down. As you remember, initially it was about 1,500 and it had come down to 500. 1 month after discharge, her blood pressure was now much better controlled. She was keeping very well, and her proBNP levels had come down to 125. Any comments so far from the panelists?
Okay, I'd like to make two comments or two questions. This got to do with economics in medicine and management. Now, we have done NT-proBNP in this lady. It helped us with the diagnosis of heart failure. I noticed, Dr. Nazrul, that you have done NT-proBNP estimation during each clinical visit. NT-proBNP is not really cheap, so maybe you can tell us whether it's necessary to do an NT-proBNP level during every follow-up, or can we go clinical?
Okay. That is a very good point, Dr. Kanan. So the NT-proBNP levels in patients with established heart failure, when they do come into the outpatient setting, it gives us a prognostic valuation and also help guides us in terms of how aggressive our treatment should be. I do agree that patients do not need to get BNP levels at every clinic visit. Once they've improved clinically, I think maybe a BNP level once or twice a year would be sufficient. And from then on, we can go clinically.
Yeah, the other point is about the use of drugs. Now, this patient, the cause of the symptoms obviously is the hypertension. Now, we have chosen Entresto, which is a very good drug for heart failure, but unfortunately, it's also very expensive. So, if I was to use any other antihypertensive agent, like an ACE inhibitor or ACE receptor blocker, and continue with the calcium channel blocker that she was on before and bring her blood pressure down, do you think that we would be able to achieve the same prognostic numbers as we would with this combination of drugs we are using?
Okay, again, a very good point, Dr. Ganesh. So, just to illustrate that in patients with hypertensive heart disease, what happens at a cellular level is that there is cardiac myocyte hypertrophy. That also leads to activation of the RAS system, which then leads to fibrosis of the heart muscle. So basically what happens in uncontrolled hypertension, you get left ventricular hypertrophy, the ventricle becomes very stiff, and then that leads to diastolic dysfunction and subsequently heart failure with preserved ejection fraction. So we have multiple choices of antihypertensive medications that act on different pathways to bring down the blood pressure. So in this particular case, if I were to choose a different drug, I would probably go for either an angiotensin receptor blocker or an ACE inhibitor, namely because of their ability to negatively remodel back the heart and to improve the blood pressure. So for her, I would specifically choose an ARB or an ACE inhibitor if I were to not use an Entresto.
Sometimes a combination of ARB with thiazides would help because it brings down the systolic blood pressure. Just a follow-up on this point, you know, as doctors, we have difficulty in controlling our blood pressures in patients, and the follow-up has to be very, very regular. So sometimes patients have an aversion for medications. Like this patient is only on amlodipine and her BP is 170/90. At this juncture, I would like to introduce this topic of renal denervation. You know, renal denervation is a good indication for patients who avoid taking drugs, who do not like to take too many drugs, and their BP is not well controlled. Renal denervation has brought down the blood pressure, and patients sometimes have taken off their medication after these procedures. So we should consider renal denervation as also a second or third line therapy for patients with intractable hypertension or patients who do not like to take medication.
Can I just add on to that? Renal denervation is expensive, and from what I've seen in the literature, the amount by which the blood pressure comes down is not very great. So I think the baseline is still drug therapy, and only if drug therapy really fails, then we go on to that. Would you think so?
These indications for renal denervations have changed. In those days, we used to have to form four types of antihypertensives, and if your BP is still more than 160/90, despite being on a thiazide and a beta blocker and an ACE inhibitor, then it's an indication. But now, after the Spiral 3 trials, Simplicity trials, if you are even one drug and if you have the blood pressure not controlled, it is an indication for renal denervation. It is definitely an expensive procedure, but we can work around it actually. If I can mention that some government hospitals like Sedang and IJN are doing at a subsidized costs.
I think we better move on because we have two more cases. Naveen, you're next, isn't it?
Yeah.
Slide.
Let me see.
Very good afternoon, everyone. Thank you for joining us today. So, my case is of a 54-year-old Malay lady. She's a corporate trainer and was recently diagnosed to have breast carcinoma stage 4. So, it had actually locally advanced to the ribs, and she was started on chemotherapy. No surgery was done as of yet. And she has been responding well to treatment. So her job entails giving lectures and seminars, and she complained that she's been feeling slightly out of breath for the past 3 months. So she just thought it's part of the disease due to the cancer and so on. So she didn't take it so seriously until the day before when she actually had an episode of chest pain. So when she went to see her oncologist, she did mention briefly, she said that, I had this episode of chest pain. It was center pricking in nature, lasted about a minute, but she thought it was nothing, and she thought she was coming to the hospital the next day, so she just casually mentioned it. So the oncologist then called me and said, Naveen, can you see this patient in your clinic? So, she came in and I saw her. She was not pale, not cyanosed. Blood pressure, I would say borderline for a lady, about 100/60. Pulse rate about 94 beats per minute. It was regular. She was on the obese side with a BMI of 32. Afebrile. Oxygen saturation we checked outside the clinic was about 96% under room air. Respiratory rate was about 20 breaths per minute. Lungs were clear. CVS, no murmurs heard. Her JVP was not raised, and there was no pedal edema as well. So just based on this brief history and clinical examination, Dr. Kannan, would you want to discuss about the possible differential diagnosis for this patient?
Okay, I think when we look at the history and physical examination, some of the points are her symptoms have been present for 3 months. This is not an acute presentation, except for the history given of chest pain the night before. So the relevant points in the history and physical examination are: she has got a stage 4 malignancy, she's obese, her blood pressure is lowish, there's a mild increase in heart rate, and her respiratory rate, from what you have found in the exam, is in the upper end of normal. So with this in mind, the differentials to consider obviously will be ischemic heart disease first, given all her comorbidities. Then her obesity and has to take into consideration. Heart failure obviously is also something to be considered, although you don't have very strong clinical signs for it. Now, anemia is something I have to look for when I investigate. That could cause her symptoms, though it doesn't explain the chest pain. Certainly, lung wall secondaries due to malignancy could have caused that chest pain. And so, lung pathology, besides lung wall secondaries, whether she got secondaries in her lungs, those are things I would think of.
Yeah, I agree with Kannan. Actually, when the oncologist called me and said they have a patient with stage 4 breast CA with chest pain, the first thing that went through my mind was, probably this is a case of costochondritis, or something that has metastasis to the rib and is causing pain. So after seeing her, I sent her for an ECG. So this is a ECG. Kannan, would you like to comment on the ECG?
Okay. The obvious things are there's mild T wave inversion in several leads, mainly I think the precordial leads. Now the T waves are not very deep. Sometimes we see this in obese ladies, females, so maybe non-specific or maybe supportive of the differential of ischemic heart disease that we considered right at the beginning.
Yeah, so I totally agree, Dr. Kannan. You do see this commonly, this pattern in ladies, especially if they are obese or with pendulous breasts. But the thing is, I actually had the advantage of going through her old records, and I looked at her ECG done a year back. So there, no doubt there were some T inversions there, in V1, V2, but if you look at the latest ECG, there's definitely some new changes, there's some progression. So that got me thinking that, this is probably acute coronary syndrome. And then again, when I looked further into her records, I noticed that she's been having dyslipidemia, not on treatment. She's obese. She did mention that her father had ischemic heart disease. So at that point in time, the diagnosis on top of my list was acute coronary syndrome. And then I sent her for some blood tests. Okay, so this further cemented my suspicion of acute coronary syndrome, because if you can see here, the cardiac enzymes are elevated, right? The CKMB, the cutoff is below 3.6, hers is about 8.2. Not very elevated, but still it's abnormal. And also the CK, liver enzymes are slightly elevated as well. And then a troponin was done. So the troponin was very elevated, right? Our cutoff is below 14, but hers was 166. And the other differential that we had in mind was, of course, pulmonary embolism. So I sent off a D dimer as well. So that's the D dimer results. Dr. Allen, would you like to maybe just briefly comment on the D dimer results?
Okay. Thanks for getting the control dogs involved. Yeah. What is a D dimer? First of all, D dimers are actually breakdown products of clots which are already been formed and then they're breaking down. Okay, so it's a sensitive test to pick up thrombosis. However, it's not so specific.
Correct.
That means it's if it has better negative predictive value. A lot of other things can cause positive D dimer, such as inflammation, surgery, infection, and things like that. So if you have a positive D dimer, then it is suspicious of thrombosis or embolism. The reliability will depend on the kit sensitivity. So this is not strongly positive. This is a bit equivocal in the laboratory.
Yeah.
Yeah.
So that's what I thought as well. The D dimer wasn't markedly raised, but the cardiac enzymes were raised. There were new ECG changes. So again, I was thinking about acute coronary syndrome, but at the back of my mind, I couldn't rule out pulmonary embolism because she had the risk factors. Recently diagnosed to have breast CA, obese. So I decided to do another test, and I thought that will help me with the diagnosis. So Dr. Kannan, what would you do next? What bedside test you think will help with the diagnosis?
Okay, I will bedside. So maybe this might not be bedside. I would ask for a chest X-ray. That's one, and obviously the next one would be an echocardiogram.
So, I mean, of course, I had the echo more accessible to me in my clinic, right? So I sent her for an echo, and this is the findings. I'll get Dr. Shambros to give his 2 cents on the echo findings. I've labeled it for you, Shambros.
Okay, thanks. So if you can orientate yourself, so the RV usually is, if you look at the ratio, the RV and LV should be less than 1, the RV size compared to the LV size. Here, the most obvious feature, the RV is dilated. So that's the most obvious thing to me, given the history and the background. Looking at this straight away, my differential diagnosis would shift towards pulmonary embolism in the first place rather than acute coronary syndrome. Even the ECG changes and the T inversion can be explained by RV strain pattern. Now that we've looked at this echo, so on the right side of the screen, you can see the short axis view. So you can see this flattening of the LV septum. I think both
pointed with the yellow arrow. You can see.
Yeah, systole and diastole, indicative of both pressure and volume overload, which is again, puts pulmonary embolism at the top of the differential diagnosis.
Yeah. The other thing is, you may even see this in patients with sleep apnea, pulmonary hypertension, but this is something more acute. So
before we go on, with these echo findings showing marked enlargement of the right heart chambers, particularly the right ventricle, could we explain why we saw those ECG changes and why the trop T was elevated? Can we tie that in?
Yeah, I mean, if you have a pressure and volume overload at the RV, you can have a strain ECG changes, in relation to RV pressure and volume overload. So I think the ECG changes more in relation to the RV changes, the dynamic RV changes that's happening because of the pulmonary embolism. And when you have increased RV strain, you can also have myocardial damage. So I think the troponin and the CKMB were elevated due to the RV strain rather than acute coronary syndrome. So troponin and CKMB can be elevated for many other reasons. It's not just specific to acute coronary syndrome. Usually, if you have proper MI, you usually see it more like thousands, like 900, 1,000, 2,000, even as high as 24,000, the troponin. So to put it in context, the HS troponin elevation to me wasn't that markedly elevated, having seen the range of troponin that you can see in acute myocardial infarction. Would you agree, Navin?
Yeah, I agree with you, Shanghai.
Yes, true.
Okay, so this is just a diagram to illustrate what Dr. Shamrose actually explained. So if you look at the four-chamber view here, you can see that the RV is dilated, and the LV is compressed in severe cases. And in the short axis, again, you can see RV pressure overload will cause a D-shaped septum, right? So, of course, there are other signs they can see, but these are the most common ones that we look out for. So what will be the next step? Because the next step is going to be a test that is supposed to be the gold standard so that we can establish the diagnosis and start treatment as soon as possible. So, no doubt about it, the patient needs a CT pulmonary angiogram. So that was done. And the good thing about doing a CTPA, I can also do a CT coronary at the same time to do a double rule out. I can also rule out coronary artery disease. And I didn't put up the images here, but her coronaries were pristine. So that definitely put it out of the picture. And the CTPA actually showed filling defects in both left and right pulmonary trunks. Maybe not very clear here, but you can see some filling defects here. I pointed it out with the red arrows. And again, in this picture, it's clearer. Right? You can see the filling defects. These are actually thrombus. And she has bilateral pulmonary embolism. So now that we've actually established the diagnosis, we need to treat her as soon as possible before she deteriorates clinically. Okay, so in patients who present with acute pulmonary embolism, especially those with low or intermediate risk, the mainstay of treatment is anticoagulation. So we can either give them low molecular weight heparin or unfractionated heparin, which is not used so commonly now, I think. And then we also have the newer oral anticoagulants. But if the patient shows any signs of hemodynamic instability, then it's indicated for reperfusion treatment. Reperfusion treatment is either with systemic thrombolytic agents or catheter-directed therapy, right, where you can actually inject the thrombolytic agent, or you can even do a thrombectomy where you can manually remove the clots. Dr. Kannan, any comments on?
No, I think we're gone.
All right. So I put up the options to the patient, but she was a very anxious patient, and she was telling me, what if you start me on the treatment and I deteriorate further? Now I'm okay. What if I collapse? So she had a lot of doubts and worries, and I discussed this with the family members as well. But of course, while waiting for her to decide, I gave her a stat dose of low molecular weight heparin. And if you see this, she finally decided to go for a catheter-directed treatment, right? So we're lucky to have Dr. Alex here, our interventional radiologist, who does deal with these kind of cases. So I'll put up this pulmonary angiogram. So again, you can see that filling defect. I pointed it out with the arrow. So that's actually the embolus sitting there. And this is how he removes the clots with a device called penumbra. It's a thrombectomy device. So you actually put in this catheter and you suck out. It's actually attached to a vacuum device, and you actually manually remove the clots. So this was done on both sides. And if you can see here, this is what he managed to aspirate. With some sound effects running. Okay, a very large clot. Okay. And this is the device, penumbra. So the blood is actually sucked into this device, and then there's a filter here. So whatever clot, will be retained here. But this clot was so big, it actually blocked off the catheter, so he had to manually push it out. Almost look like a juice blender.
No weekend juice today.
And so this was the clots that was finally aspirated from both the right and left pulmonary
It's quite a
trunk.
lot, huh?
Yes.
Quite a lot.
And I repeated the bedside echo, and almost immediately you can see that RV overload has actually reduced, the pressures have reduced. So,
So the RV size comes down immediately?
yes, almost immediately you can see an improvement. So that's my last slide. Any comments?
So very, very impressive results.
Yeah.
But to keep things in perspective for the audience, I think the literature today, the use of what do you call this devices to aspirate thrombus in patients with pulmonary embolism versus using thrombolytic therapy is still controversial. I think there's no complete agreement, except in patients who have got hemodynamic embarrassment. BP is down, so then this device thing is more people accept. And someone like this lady who presented, I think the jury is equally divided between device and using a thrombolytic agent. I mean, certainly people who use a thrombolytic agent, they would not be comfortable with heparin, seeing that the RV is so dilated.
So the ESC guidelines in 2019 did mention that systemic thrombolytic are actually a class 1 indication for a patient with hemodynamic instability. And if you're talking about thrombectomy, it's a class 2A indication. So, rightly, as Dr. Kannan said, first option can be systemic thrombolytic agents.
What about just anticoagulation alone without thrombolysis? Was she unstable to require?
Well, her blood pressure was borderline, and her sats were about 96. So, we can always adopt that, wait and see approach where you can give them oral anticoagulations, and then if they don't improve or they deteriorate, then you can go in for systemic thrombolytics and all that. But I think that may increase the bleeding risk during the procedures and all that. So we need to decide beforehand as well. But if patients who have low or intermediate risk, very stable patients, then you can just start them off on oral anticoagulations.
I think
The
for the
algorithms also show that if you can demonstrate an echo, RV dilation, chamber dilation like this, that means the right ventricle is under strain. There's an indication for thrombolytics over heparin.
Correct.
I
So if
think,
you look
I
at
think
this slide,
someone like this, most people would not be comfortable with heparin alone.
so if you look at this slide, if there's RV dysfunction or clinical signs of pulmonary embolism severity or serious comorbidity, then reperfusion therapy with thrombolytic agents is indicated.
I mean, quick one. Why did this lady chose an invasive procedure rather than thrombolysis? Was it because she was worried about the bleeding risk or something? I mean,
we put up the options to her. She wants something immediate, something that she could see with her own eyes, So she decided on that. So,
But
Maybe
this,
a little beyond.
sorry, this thrombolytic therapy is catheter directed into the PA, is it? Or is
No,
it
no.
a systemic?
Systemic.
So it's not going to work.
Definitely
Because
work. We have seen it many times.
It's
Yeah.
not a clot she has got.
No. But I've seen it many times. RV is dilated. You give TPA, and next morning you find things begin to improve.
Peripherally.
Yes.
see the interventional radiologists here, they do manual thrombectomy. In some cases, they even inject a bit of thrombolytic agents.
That's what I've seen.
Yeah.
You inject into the thrombus.
Correct.
But now experience over the years, the intravenous thrombolytics have been very impressive.
Works very well, yes. For very unstable
Yeah.
patients.
Yeah. So long as the PP is okay.
So I think our hospital, we have the facility, so
But expensive.
expensive.
There's some potential for damage, but perforate the lung.
Yeah.
What's the cost, Navin, quickly before we move on?
I think it was quoted about 100K.
Okay. Must
This
have-
procedure.
Yes, 100K, yeah? Okay. Nazrul, next one.
Thank you, Navin, for the very interesting case and discussion. So the next case is that of a 49-year-old female. She came in with similar complaints this time, exertional breathlessness, and she was actually admitted for COVID. Her background history: she's an asthmatic, she's got cervical spondylitis, she's a non-diabetic, she doesn't have hypertension, and she does not smoke. She was actually referred to me on day 5 of COVID infection. At that time, she was stable. She was afebrile for the past 2 days, but she had persistent tachycardia. So on further history, when we speak to her, she actually has been having exertional breathlessness for the past 3 months. She denies any symptoms of chest pain. She doesn't have any heart failure symptoms. In 2021, she actually had a stress test and an echo done, and she was told that everything was normal and fine. So on physical examination, we found her to be obese. Her BMI was 28. She was pink and her JBP was not elevated. Her blood pressure was normal. She had a BP of 101/80, and she was tachycardic, as you can see. Her heart rate was 105 per minute. On auscultation of the chest, her lungs were clear. She had dual rhythm, no murmurs heard, and she had no pedal edema. So just based on all of this information, I would just like to ask Dato' Bala, what could be the possible diagnosis or working diagnosis for this lady?
So we have a 49-year-old lady who is an asthmatic, and physical examination, her lungs are pretty clear. So, but what stands out here is that she's having COVID. So we do think of a patient with COVID, with tachycardia, whether pulmonary embolism should be entertained in her. The other thing is long-standing asthma, whether she has got an element of COPD on her. Other aspects of heart failure and right ventricular failure can be looked into, but definitely COVID with pulmonary embolism will be a main differential here.
Thank you, Dr. Bala. So we did a couple of tests for her. Now, the first thing is that this was a ECG actually in 2022, last year. Dr. Shamus, would you like to just give a few words on what we see on the ECG?
Nothing remarkable on this one, just sinus rhythm, no acute changes.
Exactly. So now, this was an ECG during admission. What do you think about this?
Tachycardia.
Okay, I mean, the most obvious thing, she's in sinus tachycardia. But I think now she's also got this RBBB pattern. Maybe you can point out for
Yes.
that.
Correct. Now, so yes,
Inversion to anterior and inferior leads.
Yeah. So I think looking at this ECG, I think the first thing that will come to mind is whether she's having pulmonary embolism, especially with the background history of COVID. So this was a chest X-ray. Shamus, anything you'd like to say? So this was an AP sitting X-ray.
Okay, so yeah, so epiphyllum, but again, the cardiac cellulite, the size looks enlarged to me, and I'm not sure whether there's some upper lobe diversion as well in this X-ray.
So this
can we just one moment?
Yeah.
I think the serial ECGs are interesting, especially for our friends, general practitioners. So if you have got serial ECG change in the setting like this patient, and with what looks like new onset right bundle branch block, this is something that we see in pulmonary embolus, isn't it? So something that we want to point out. Okay.
So these were her routine blood tests. I would like to get Dr. Allen's help again to just give a few comments on this.
Give me a second. I don't know what happened to my screen. Okay, I think the striking thing there in bracket is eosinophil 22%.
Yes.
But I think we should not look at percentage. I think it's important for, especially for the GPs, is calculate if the lab doesn't present you with the value, calculate the absolute eosinophil count. So it's more important because 22% of 5 is very different from 22% of 10. And here we have 22% of 12.2. And nowadays I need a calculator. 12.2 times 22% is 2.6. So that's 2.6 times 10 to the power 9 per liter. And that's very, very high. Normal eosinophilic range is roughly about up to 0.4 or so. And what is termed hyper-eosinophilic range is when the absolute eosinophilic count exceeds 1.5. And there is the concern about this is whatever the cause of this tremendous increase in eosinophils, if it's allowed to persist, then you can end up with something called a hypereosinophilic syndrome. So, which can lead to the eosinophils are toxic to tissues, and you can get end organ damage to the nerves, the brain, the heart, the lungs, and so on. So you can get symptoms depending on what disease. I've seen things ranging from pneumonitis. I had a man who was a retired engineer who became demented due to hypereosinophilia, due to taking antibiotics. He was a hypochondriac, so he took used antibiotics, and then he had developed hypereosinophilia, and then he became demented. We stopped, treated it, and he became back to normal. And we did this as a case report. I still strikingly remember this case. So whatever it is, I mean, it's very, very high. So we have been concerned about the development of hypereosinophilic syndrome if she has not had it already, whatever the cause. And it can be primary or secondary to other various things, drugs, allergies, or myeloproliferative disorders.
What about asthma per se?
Asthma can cause eosinophilia,
Yeah.
but usually not at this range. Not this range, yeah.
The other thing that I would like to point out was that actually last year when she had her full blood count done, her eosinophil counts were actually normal. Yeah, so this was something new that you were detected in the blood.
Alan, have you seen this in COVID patients, Alan? Hypereosinophilic post-COVID infection?
I think, as far as I know, COVID causes eosinopenia. So it's not euphilia, yeah.
The monocytes.
It will drop, yeah. Usually the lymphocytes, monocytes can be a bit high. The eosinophils, no, the other way around.
It's quite odd. She just had
Something has triggered it off. Looks like needs some hematology input to find out why. Yeah.
yes.
Besides that, we also see that her CRP counts were high. Liver enzymes were also slightly deranged, and this could all probably be explained by the COVID infection that she was having. Yeah. So now moving on, this is her echo findings. Yeah. So what we found was that if you can see on your left hand side, what we're looking here is the apical 4-chamber, and the arrow is pointing at the right ventricle and the right atrium. So you see the right ventricle appears similar to Dr. Navin's case, is grossly enlarged compared to the left ventricle, as well as the right atrium. On this view, we can't really visualize the tricuspid valve, but when you look at the image in the center here, this is the RV inflow view, and what we're looking at here is the right ventricle, and this is the right atrium. So the tricuspid valve here looks like it's thickened, possibly it's not opening well. And when we, on the right hand side here, as we put the Doppler flow across, we can see that there's a jet that's going across. And this is highly suspicious of possibly that she's having tricuspid stenosis. Now, the interesting thing is that this is not something very common that we see in this age group, or rather, it's not something that we commonly see in general. There are a few causes of tricuspid stenosis, and to better get an understanding, we actually need to visualize the valve properly. So what we did was we actually proceeded with the transesophageal echocardiogram, and this is what we could see, right? So again, if you look at the image on the left-hand side, the arrow is pointing at the right atrium, and this is the right ventricle. You can see that the right ventricle is grossly thickened, as well as the tricuspid valve is also grossly thickened. And when you look at the image on the right-hand side, and we put the color flow Doppler across, you can see there's a jet going across the tricuspid valve. So, in fact, this confirms that she does have tricuspid stenosis. Now, one of the commonest causes of tricuspid stenosis I could think of would be rheumatic heart disease. But then again, the incidence of rheumatic heart disease is decreasing. We commonly see it mostly in the east coast of Malaysia. But again, if she does have rheumatic heart disease, number one, it commonly affects the left-hand side valves. We will also expect her to have a more calcified and fibrosed valve, which would appear as bright colors on the valve, which we don't see here. The other thing that I could think of is whether she's having infective endocarditis. But then again, she was generally very well. She was not on any antibiotics at that point, and she was recovering from a COVID infection. We don't see any signs of vegetation on the valve. And again, infective endocarditis mostly affects the left-hand side heart valves. Usually for right-sided valve, we would generally see them in immunocompromised patients, those with end-stage renal failure or those with drug addicts, and correct.
And all that doesn't explain the right ventricular hypertrophy also.
Yeah.
Yes, correct. Agree, Shamus. So this is the bicable view of her trans esophageal echo. So what we're looking at here, this is the right atrium, and you can see here, this is what we call a spontaneous echo contrast. This indicates that the blood flow across the valve is sluggish. And when the blood flow is sluggish, what can happen is you can have clot formations.
Yeah.
So over here, as you can see this point here, this looks like a clot in the right atrium. And this segment here, you can also see clot all over the right atrium wall. Right?
That's true.
So now this is something that's very unusual. So now we have a lady who was diagnosed with COVID infection. Subsequently, she's now have symptoms suggestive of heart failure. Yeah, but when we look at the history of this case, her symptoms actually started 3 months prior to her admission. So she probably would have been having this lesion probably before her COVID admission, and now we actually need to find out what is the possible cause. So we don't think it's rheumatic heart disease. We don't think it's infective endocarditis. The other thing that we could possibly think of, which is not very common, is whether she has got carcinoid syndrome and carcinoid heart disease. So what we did was we did.
Can I ask something before we move on?
Yeah, sure.
When we were looking at the biochemistry, we found that the liver enzymes were abnormal, and we thought that the COVID may be the cause.
Yes.
Now that we have seen the echo, can we find another explanation for why the liver enzymes could be abnormal?
Well, looking at this, possibly she may be having liver congestion because of the poor
Right-sided
flow.
failure.
Yeah, so right-sided heart failure, then that would lead to raised liver enzyme.
Yeah, good point.
So what we did next was we actually did a CT pulmonary angiogram for her, a CT thorax and a CT abdomen. So what we're actually looking for, we wanted to rule out pulmonary embolism due to a COVID infection, and we didn't see any. Now the CT thorax and the CT abdomen was done because we're mainly trying to elicit whether she's got any carcinoid tumors, which are neuroendocrine tumors that commonly affect the lungs as well as the colon. Now we didn't see any lesion both in the lungs as well as the colon, but what we did see was that this is actually the inferior vena cava, and you can see a filling defect here, and what we see is thrombus formation in the inferior vena cava. We don't see any lesions across the liver, so we don't think that this could actually be due to carcinoid heart disease, because usually in patients who present with carcinoid heart disease, you would expect metastasis ovary to occur in the liver itself, so we don't see any of those here. Now, the thrombus formation in the inferior vena cava could be multifactorial. Number one, the sluggish flow in the right atrium could lead to clot formation, and subsequently the clot could extend into the inferior vena cava. The second thing is that the COVID infection itself, I think, could also predispose her to clot formation. The third thing that I could think of is that Dr. Allen did mention hypoeosinophilic syndrome. I think in patients with hypoeosinophilic syndrome, they are also predisposed to thrombus formation both in the venous system as well as in the arterial system. Yeah. So the next step, what we did was we did a cardiac MRI actually to better delineate the heart structure. Yeah. So maybe Dr. Shamus can give us a word or two regarding this.
Okay. Basically, maybe Nazrul can point out the right side. I mean, the most obvious features, the RA was hugely dilated if you compare to the LA. And then the RV wall, as I mentioned before, RV wall usually is less than 0.5 centimeter, the wall thickness. You shouldn't really see RV wall hypertrophy. This is very overt, even more than the left ventricular side. So something is happening. I mean, with the hypereosinophil count, we worry about things like, on MRI, one of the top differential would be some sort of endomyocardial fibrosis. And sometimes it can overlap with HES syndrome. Maybe Alan can comment more about this. And there's also pleural effusion on the right. There's also pericardial effusion. Is this some sort of myocarditis, affecting the RV specifically? I don't have all the pictures. The MRIs was done outside. But in the report, they mentioned that they saw subendocardial late gadolinium enhancements in the RV apex, which again is consistent with apical RV wall fibrosis, some sort of fibrotic process, which again can affect the tricuspid valve apparatus. See, it's not really the valve that's thickened. You see, it's just the atrioventricular valve apparatus that's thickened, causing some sort of functional tricuspid stenosis. Whether this is all related to the fibrotic process, I'm not too sure, unless you do some sort of biopsy to confirm the diagnosis.
That's right. Biopsy.
So putting all this.
Can I ask you something, Shamruz? your MRI, does that
Yeah.
show this pericardial effusion
Yes,
in addition to the pleural effusion? And why would this lady have pleural pericardial effusion?
So, see, when you have a myocarditis or inflammation, you see this commonly. The pericardial effusion is indicative some sort of inflammation in the myocardium. So we see this commonly in myocarditis. So
What about
that's
heart failure itself? The right heart
heart
failure
failure
itself?
itself can also cause, yes, the RV failure.
So, putting all this information together, just like to pose the question to the panelists: what do you think would be the possible diagnosis, and what would be the next best step for this patient?
I mean, certainly could be eosinophilic myocarditis,
Yeah.
but given the changes here, I mean, it's after all an inflammatory myocarditis, but the only definite thing you need tissue to
Biopsy.
confirm it's actually eosinophilic infiltration in the heart muscle. And but could there be other causes of myocarditis in this?
But this myocarditis, how often do we see it so focal, involving only the RV? Isn't it something more?
Most of the case report suggests that it affects the left ventricle, or even both the left ventricle and the right ventricle. But we've not seen any case report that have suggested that it affects the valve itself. We've not seen that. Yeah, so this is.
I mean, if it's hypereosinophilic syndrome, in about 10% of cases, it's isolated to RV alone. Not common, but happen.
So what about biopsy now?
Okay, so she is actually planned for a
Oh,
cardiac
she's planned
biopsy.
for it. Okay.
Yeah, but the reason that this is delayed is because of the amount of clots in both the right atrium and the right ventricle. So she's been given anticoagulation. She'll be reassessed again, and then she's planned for a biopsy. Yeah.
So now she's on what? Some antithrombotic agents?
She's been given warfarin for the time being. Warfarin, yeah, and as well as diuretics.
Was she given steroids in the course of her COVID? Because I'm curious because quite often in COVID you give Dexa
Hypereosinophils.
because the steroids would actually normally be the treatment for hypereosinophilic syndrome. So
She was given prednisolone tablets during her course, but it was only a short duration for 5 days.
I mean, it wouldn't be too difficult to quickly, from the history, examination, and some tests to exclude, whether there are any drugs, parasitic infection, other collagen disease or lymphoproliferative disease. You can quickly try to exclude, and then if you don't think it's any of these, then it's probably primary, whatever it is, and you don't want to delay. And the treatment is actually with steroids. And steroids will quickly bring down the eosinophils.
I think biopsy is quite definitive.
Oh, sure. But I'm saying
that will decide
Yes.
for your plan of treatment.
Yeah.
Based on this information, would it be sufficient to start the patient on steroids at this point in time?
This is a bit complex because here we got COVID patient as well, and the possibility of whether that has could be an underlying cause. I've no idea. What do you all think about the COVID itself?
But serositis is quite major. She's pleural, she's myocardial, and I don't know whether the abdomen is involved. So it's quite a major thing. Must start treatment fast.
So was he started on any anti-failures as well? I mean, in terms of while waiting for the biopsy is going to take some time. So how about symptom relief?
So she's been put on diuretics, and I've put her on spironolactone as well because of the RV failure. The left ventricle is functioning quite well.
And the other thing I wanted to ask is why warfarin and not one of the newer oral
I think because there's no data for NOACs in clots per se. I think in RA clots there's no data, so I think warfarin was the choice of drug.
Right. Because she also has the DVT, which basically has.
She doesn't have
pulmonary
DVT.
embolism.
No. She just has clots in the right atrium, the right ventricle, as well as the inferior vena cava. Yeah. So that's why we chose warfarin instead of NOAC. But look, any
Very interesting.
Good case. Alan, any questions from the audience?
Any more cases of this? Oh, okay. I'm just probably the audience is overwhelmed by the complexity. These are very unusual cases. I think both of them are quite unusual, especially the second one is very, very complex. and very interesting. I actually don't have any. There are no questions actually.
They're in shock.
There's only one comment. Good question on economics, Kanan. That's the only. I don't know what you mentioned about economics.
I think the general practitioners are always worried about the costs.
All of us are, except for Datos, they are not. We all are very worried about cost.
Okay, let me show the Slido screen again. If you have any question, please don't get excited. This QR code is not the MMA point. Huh? This is the Slido QR code to get you to Slido. We'll just few seconds anymore. If there are no questions, then we are going to go on to the CBD point. Huh? All right, now you can claim the point by launching the MMA app.
Can I do that?
And yes, all can. You can open the MMA app and click on the scanner portion. And then if you're watching it on, say, your laptop, you can use your phone with the MMA app to scan the point, which is coming up now. Okay.
Okay, so I scan this. Huh?
Yes, just open up and let me check.
Okay, masuk already.
Yeah. If you are watching with your phone, you can now scan, but you need to take a screenshot. All right, you need to take a screenshot, and then in the MMA app, you will see at the bottom right there something called gallery. So you can actually open the saved image.
Album.
Album. Yeah, because you can actually scan the QR code from a saved picture.
What do I do? Select the photo? Or
No need. You just scan. Yeah.
I scanned it, but then
Everybody managed to get your point? We are in July, so we're very early in the CPD cycle. 1st of July until 30th of June next year. But don't leave things to the last minute. So just want you all to, if you appreciate the efforts of our wonderful panel here,
thank you so much.
yeah, please do like and subscribe to our channel, as they say. And so you'll be notified of our upcoming CPD. We hope to have one every month from SJMC. All right. Next month is hematology grand rounds. Now I got something. We got hematology grand rounds next month, and then so on. Yeah. So stay tuned for more, and thank you all for attending. The code will be active for about up to an hour, so you'll have time to scan first. After an hour, it will expire. Okay, so have a good weekend, everybody, and thank you once again, and thank you for everyone for presenting as well as watching.
Okay. Thank you for
Thank you for watching our video. If you enjoyed the content, please don't forget to hit the like button and subscribe to our channel. Also turn on notifications, so that you won't miss our upcoming videos.
Very good, thank you. Very good, nice piece.
Yeah, amazing. The pieces are very good.